Kia ora, I'm Christian Robinson, Urology Registrar at Dunedin Hospital in New Zealand, and this is a feasibility study looking at the role of intraoperative flow rate during TURP procedure as a marker of efficacy. I have no conflicts of interest to disclose. We face an increasing demand for bladder outlet obstruction surgery in an aging comorbid population. We need to identify the correct patients and minimise complications in this group. Failure to avoid and surgical revision are the most common complications following TURP. Some perioperative clinical and ultrasound features can predict catheter-free outcomes. And some urologists apply pressure to a full bladder to express its contents as an indirect measure of urinary flow after prostate resection. So could this technique of intraoperative flow rate act as a marker for success following TURP? Our aim is firstly to describe an intraoperative flow rate technique and assess its practical feasibility. Secondly, to assess Chambers' test as a marker for determining catheter-free success after TURP. And finally, to determine if this flow rate would change management in specific patient groups. This is a single-centre prospective cohort feasibility study. Patients proceeding for TURP with indwelling urinary catheters due to recurrent retention who had failed medical management were included. Chambers' test consists of a flow rate that's measured immediately before and after resection. The bladder is filled with 300 mL, then on average 50 newtons of force is applied to the abdomen by a single operator to void the contents. The voided flow is graded on a 0 to 5 preset scale by 2 assessors. A routine TROC protocol was carried out by blinded ward staff and then followed up in clinic at 10 weeks. Flow rate data was collected and correlated with catheter outcomes. The feasibility results show that the on-table Chambers test took about 2 minutes to complete before and after resection, predominantly due to bladder filling time. The technique proved to be simple to perform and straightforward to follow with feedback from the operator, assessors and theatre staff. The first 300 mL was used from the standard glycine fluid bags for the operation. No extra equipment was necessary and the impact on resources therefore minimal. The learned technique applying abdominal pressure appeared reproducible. Assessors reported the preset flow scale as being clear-cut. The same operator and assessors were used in every operation, creating familiarity with the process and removed the potential for poor inter-rater variability. 17 patients proceeded for analysis. This is the average flow scores before and after resection, as well as the change in flow. It shows that those who had a successful TROC and were catheter-free by follow-up had significantly higher flow rates than those who failed and were catheter-dependent. An ROC analysis compared specific flow thresholds and the diagnostic ability to predict a successful first TROC and catheter-free by follow-up. You can see the combination threshold in red of post-procedure flow greater than 4 and a change in flow of greater than 2 had the greatest predictability. You can see the area under the curve for the same combined score threshold has increased here and suggests Chambers' test was more accurate predicting the long-term outcome being catheter-free by the 10-week follow-up. This summarises of the 17 patients, 14 had a successful TROC. 11 of these were predicted to pass by Chambers' test. The 3 that failed, all 3 were predicted to fail. The 12 who were catheter-free by follow-up, 11 were predicted, and all 5 of those catheter-dependent by follow-up were predicted. Interestingly, of these 5, 2 had a completion TURP and became catheter-free and were predicted to do so at that time. Another 2 were suitable for SPC insertion and therefore underwent a subsequent general anaesthetic procedure for this. The size of our study reflects its nature as a study of feasibility. An interventional study with an initial pilot involving a large sample size based on power calculation would be needed to verify the diagnostic accuracy. Confidence intervals and statistical significance would then have relevance. Consecutive recruitment was chosen to minimise selection bias, however several participants did not make it to the analysis because of not being consented, episodic unavailability of dual assessors, and unfamiliarity of the process among theatre staff. Education sessions within the department for staff involved and the training of more than 2 assessors would potentially mitigate these factors. Abdominal pressure should be monitored throughout the study. A more accurate and verifiable method of applying abdominal pressure would be essential if more than one operator performed the test. We suggest the use of a catheter that measures intravesical pressure. Chambers test methodology does rely on relief of mechanical obstruction and bladder outlet obstruction. Therefore, detrusor underactivity possibly acts as a confounder. However, a large, baggy bladder filled with a set volume and compressed with a set pressure may still lead to poor flow due to the distribution of the fluid in the patchless bladder. This would be of interest for further studies. The type of anesthesia, BMI, prostate size, detrusor activity, and duration of pre-TURP indwelling catheter may impact performance of the Chambers test. A large randomized study would allow subgroup analysis to assess this. Finally, we used a subjective measurement scale that was attempted to be made objective using dual assessors. However, for objectivity, we would recommend a portable uroflowmetry device in the operating theatre. In conclusion, Chambers test is a simple, reproducible, and fast intraoperative technique used to assess urinary flow before and after TURP and requires minimal resource. This technique may predict successful outcome and identify those who will be catheter-free postoperatively, but it also appears to identify those likely to be catheter-dependent despite the procedure. This could affect management of those who may need consideration of completion TURP, simultaneous suprapubic catheter insertion in some individuals, or early self-catheterization education. We recommend a larger interventional trial with initial pilot study. Thank you. I now invite any questions.